that may be to the detriment of a really important, meaningful solution that could help a lot of people. A lot of great solutions die because companies don't figure out how to get that done.
So today on the Provider Engagement Podcast, we have with us Jen McClurg. She is the principal of McClurg Healthcare Advisors and has a long history working with both payers and providers in the healthcare space. She's been involved in diabetic vision screening and implementing solutions to improve quality there, and has a lot of the experience that we're going to talk to her about today has come through that experience and ultimately coming up with quality solutions that work for the payers, but also integrate well into provider workflows so that they can actually implement those solutions for care to be able to achieve that triple aim. So, Jen, thank you very much for being here with us today.
Thank you, Will and John, for hosting me. It's good to be here.
So, Jen, usually where we start off these conversations is the folks that we have come on have that experience and the perspectives of some unique experience coming back through this whole idea of provider engagement. And ultimately, healthcare does not exist for the providers. We know that the providers are there to really be that front line in making sure that our populations are staying healthy and that they're reducing the cost of care, right? And we're all working there together with that. But everybody comes from a different perspective and with that different experience, so they can see maybe something that's a little more glaring to them than other folks, right? That they've run across. And so we generally call that the shout it from the mountaintops message. What do you see through all your years of experience and now working with your clients and your consultancy? Where do you see the biggest opportunities or the things that people need to be more aware of in terms of provider engagement, payer-provider relations, implementing these things overall to get that higher quality of care for everyone?
Yeah, so I appreciate that question. I think at the risk of sounding overly simplistic, it's an answer that probably applies in many places, which does come back to, from whatever lens you are viewing the healthcare landscape through, can you also view it through the lens of the other party that you are trying to influence or that you need something from? And so, you talk about providers and payers, and for me, there's a third element, and that is vendors who are creating and delivering the technology with the goal of helping how we do healthcare be better. And in all of those cases, what drives each of those groups, what drives the people in those groups, what we say they're hired, measured, and fired on, are radically different. The needs are different. At the end of the day, ideally, we're all focused on doing better for our patients and for the members, and helping people live healthier lives. But we couldn't have a wider variety of incentives and drivers for why we implement or prioritize one thing over the other. So I think at the simplest of levels, it is the basic human ability to stop and appreciate where the person you're working with is coming from and what challenges they're up against, so that together you can get to kind of the winning solution.
I think it's so, as you say, like at the surface level, it's very simplistic, but ultimately being able to apply that is one of the hardest things, and it has been so in a lot of different businesses. Just that empathy with the words you use there, like the incentives, like what are people hired and measured and fired on, and we could dig into a lot of those different things, but I've had this conversation a lot with folks, and it comes back down to remembering that the people that are ultimately implementing whatever solution it is, and from wherever you're dealing with, like, you're still dealing with people that have to go home, that have concerns outside of their careers. They have things that they're bringing and dealing with their families and loved ones as well, and everybody's trying to accomplish their goals that hopefully are aligned with the larger thing that we're all involved with here. But just having that perspective that we're dealing with people that are all facing some kind of battle, and maybe have a different measure of success that is ultimately different from yours in their day-to-day lives. Like that's a huge thing to over, not necessarily to overcome, but to be aware of. But that lack of empathy, how have you seen maybe some of the more effective ways or some of the successes around overcoming that, or maybe broadening that perspective of folks and getting people to appreciate the different perspectives that are out there?
Yeah, so in a very complex world of quality programs and metrics, right? We have all these equations and all of these different kind of structures for incentives, and it depends on the health plan type. It depends on what type of contract you're in. So on one level, in a very simple way, you can say, well, I need to understand how you're measured. I need to understand, what you have to accomplish to check the box and say you did your job. On the other, if you don't live and breathe star ratings and quality measures and risk adjustment and HCC codes and out to the fourth or fifth decimal place, you're only going to scratch the surface on really understanding what each of those folks responsible for those things really are responsible for. So it's interesting to an extent. I would say self-education, which is a lot of what I did over the last 10 to 15 years to be able to kind of help toe this line between we have a solution that we need the payer support for, and the solution is for providers, and it's going to disrupt their workflow. And we've got to really figure out how to bring these things together to satisfy payer needs and provider needs. For me, it really was about sitting down and doing the work to understand those equations. So I understood how the money flows, how do things work on that side. But then also, once we kind of got to the point of we're implementing these solutions in provider offices and understanding after we solved reimbursement and coding and all of these other challenges, we were still running into a brick wall that is otherwise known as workflow, right? Trying to put something else into that workflow. So then we had to stop and say, okay, now we're going to sit down and we're going to play this whole thing out. How do they interact with the EMR system? What can we do here to automate this process? How can we make this easier? At every step, it was really for us a matter of sitting down and figuring that out. Now, again, I'm speaking at this point from vendor perspective, but I think same thing if you're a payer and you're trying to influence behavior and incentivize certain results with the provider, right? Do you have an appreciation that you aren't the only health plan that provider is dealing with? They have a whole base of patients and a lot of other payers involved, and all of them have different metrics and programs and incentives, and they're all communicating different things. And that provider needs to manage and be able to kind of toe the line, but amongst all of those things and get all of those things done. And that's where I know, well, you and John and your team have a solution that really helps to kind of say, hey, look, let's bring all of these things, all these items together from the different payers. But does the health plan in the beginning understand that, right? I've got to get this done with this provider. They've got all these providers they're dealing with. Can I stop and say, yes, this provider, I know I'm not your only plan. And not only that, I think there are many opportunities, and I see this with the plans that I work with today. One of my clients today is a mobile health screening services company. So they provide things like the diabetic eye exams and others, either in a provider office or in home. And what we see is that the plan will bring this provider group to a primary care office, and the ability to say you can not only leverage this provider group to screen all of your diabetic patients for my plan, you can also schedule patients for other payers, right? So expanding the value to the provider, which is, have you got Humana or Anthem or Cigna or whoever your payer mix is? Yes, we brought this vendor, but as a provider, they can submit claims for all of these different health plans, right? And so you're expanding the value to the provider who's getting a lot of gaps closed, but you're also getting what you need. So can you think about solutions that expand the value for everyone?
Well, and just that last example, that can be kind of a tough one, right? Because you did such a great job there of just kind of illustrating all of these kind of lower tier priorities that people have that can sometimes be in conflict with one another to that big overall goal, right? So if the overall goal, we're all in this big boat together to improve the quality of care and outcomes and lower the cost for everybody. But at the same time, these payers are competing with one another. And you mentioned like understanding how the money flows and where the money flows. Like ultimately people are looking to pay their bills and bring home the bacon, so to say. And so just what you mentioned of payers being cognizant of the fact that they're not the only payer. Like some of them would really like to forget that fact. In my experience, and the things that they put out. And so I'm kind of curious about that. This last kind of solution that you talk about, like getting people to think about, like, yeah, it's okay if our competitors benefit from this thing that we're providing from to the providers, because ultimately we're going to get what we want, and everybody's going to be better off for it. Like, how was that met with resistance, or was it a hard sale in a couple of things? I'm just really curious to see how that would be implemented.
Yeah, look, we all have some level of competitiveness that we carry innately. Some of us are more competitive than others. And so that we bring that personally to whatever job that we're in. I would still say that over the last 10 years, in the work of helping to build and commercialize the diabetic eye exam solution, which we put into primary care settings, and we had unbelievable hurdles to overcome, starting with the fact that there was not a reimbursement model that would pay a primary care doc to do an eye exam for all kinds of good reasons. But having built a solution that worked using telemedicine and remote specialists for interpretation, we still had to overcome, all of those kind of hurdles one at a time. And so in that process, it was number one, convincing the health plans to pay, figuring out the coding, figuring out, testing the process, making sure those claims would clear, the gaps would close. And then also working with the providers, right, to then say, here's how we do this. But in the process, I found far more people in the payers that I worked with that would say, you know what, we're willing even to invest in and offset the cost of this equipment for these clinics, knowing they're going to use it for all of their patients. Other health plans will benefit, but it's the right thing to do, right? It's the right thing to do for these patients. And this isn't about diabetic retinopathy, but it is the leading cause of preventable vision loss and blindness in this country. 95% preventable, but a whole lot of people lose their vision every year because we don't catch it in time. So it's easy to get behind that, right? But also, it was really refreshing. Not all the plans took that approach, but to hear so many of them say, yes, we've got to get this done. This is the right thing to do. And so, again, we solved their problem, the health plan, right? We were giving them what they need. But we also helped them understand that the provider needed all of these other things. And to get that, right, here's how we work together. And the provider understood as well. They needed all of these things covered, and that it was easy for them to understand, right? We want to do this thing because it's best for our patients. So again, I think it always comes back to understanding and speaking to what is driving each of the players involved. And if you can help everybody get what they want out of it, then people might be willing to give up a little bit of that, okay, I'm helping my competitor as well, right?
Right. I'm okay with other people winning as long as I'm winning.
That's the right thing to do. That's the right thing to do. So one question, we know that the payers struggle when it comes to training providers. They come out with amazing trainings, but sometimes they're pretty much pushing that training to all the providers at the same time, thinking that they all have the same issues. So as you can see, there are some offices, provider offices, that are very savvy. They're very computer savvy. They understand how the gaps work. So the amount of training that these providers have compared to other offices is so different. So they struggle trying to come up with the right strategy to train these providers, which, like you mentioned before, a lot of those things is about training, about understanding they understand exactly what is the benefit for the whole picture when it comes to not only the health plan, but actually the member and the provider at the same time. So how in your expertise and in your consulting firm, how have you seen the process of training these providers more tailored to whatever specific needs they have?
Yeah, so I guess I would start by saying the training side of that is not one I have been involved in directly, but my reaction would really be I would have a lot of questions about how the training gets delivered, the timing of it, the content, what's required to access it, how it gets accessed, right? And again, are we thinking about all of those things through the lens of, how does this fit into the provider's workflow, but also how does the provider value that, right? Where do they prioritize it today? Can we adjust how they prioritize it based on understanding or helping them understand the impact and the influence and the criticality of it? I would want to ask all of those questions, I think, to kind of get at the answer to that. But again, basically it comes back to, do we understand what's the challenge, what is driving the challenge from that person? It's rarely about, I'm just unwilling to do this thing. It may be, I don't see it the same way you do, or I don't have the same prioritization of it.
Well, I'd be interested to hear from your perspective in terms of vendor solutions being implemented. Have you seen in that kind of a disparity, or at least a spectrum of the acuity or the ability to really be able to implement those solutions in provider offices? And that may be very specific to your experience, but I think there's a lot of lessons and generalizations that can be pulled out of that to a lot of things. And how do you address being able to help people that are basically starting from very different positions in terms of being able to get the value of anything that's implemented in that office, to ultimately be able to help them and the patient?
Yeah, on the one hand, I think over the last many years, generally we kind of move towards this model of, and payers in particular really want to kind of empower this super PCP approach, right? How much can the primary care doc deliver? And in many of these health systems, really it's also in their best interest, can I maintain the care and the control over what's going on with this patient? So how many things can we move out of a specialist office and not have to refer them out? It's also so much better for the patient, right? It's more accessible to go to their primary care. So you've got kind of all of those things to think about. But every time you think about adding a new workflow, even as efficient as you think you've made that process, it's still another workflow, it's still another thing. And so, I say if you're going to add something, something has to come off. That's not necessarily a one-to-one, I'm adding this has to go. But it may be, I'm adding this, and maybe I have to add this with a system that adds enough efficiency that we're reducing time involved in not just this, but some other things. Or we need to be adding things in such a way that they're either getting more efficiencies, or we are creating enough additional return that we can justify the additional resources to manage these tasks, right? If you're getting now the diabetic eye exam, which you weren't before, or if you're able to set up, one of my clients is in sleep apnea, and our ability now to give the primary care physician a significant amount of control over that care, to bring down the cost and to improve the process of identifying, testing, getting results, and getting someone on treatment for sleep apnea, which by the way is 80% undiagnosed today. We have the technical ability, right? We can put all of that in primary care. The process to figure out, okay, how do you make sure the primary care knows when to pull that in, how to deploy it? Can we make this push button easy, right? There's a flag, they're at risk. Can I push a button and everything else happens? We send a home sleep test out and the process kind of flows. It has to be that simple and that seamless to add a new thing into primary care, has been my experience.
Well, and that just goes, and for probably at least the last 25, if not longer. People have been talking about this gradual change of doctors just having to see more and more patients and being overloaded, and just the paperwork involved with reporting on quality measures or risk adjustment. Those things are already this overwhelming burden, and they're having to invest more resources into medical assistants or folks that can take that on. And now all of these other specific quality measures, like you say, vision screenings, that we hear it a lot from primary care physicians. How they didn't go to med school to learn medical coding, right? And yet that seems to be a lot of what they're having to invest time in. And realistically, that may be changing now and some of these other things. But you think about a general internist, like they probably never thought they'd be doing eye exams, right? Because they didn't go to optometry school, or unless they became an ophthalmologist, right? And so what I think the big takeaway there that I think everybody needs to think about is just exactly what you said. If you're adding something, you have to take something away, or you have to be able to show the return to generate the resources. Like at the end of the day, it has to be a net benefit. And so there can be costs involved with that as long as the return is going to be greater on the back end. But that comes with a large level of communication as well, and being able to help people see that, because so many times when if you're stuck in the weeds, or you're too close to this thing, or you're already up to here, seeing patients, and there's not another hour in the day before you can even think about how much time this might save you, or how much additional revenue this may come in, and you can hire another system. You just see this one more thing, this cost that comes up, and it's very easy to just resist that and just kind of stick with the status quo until you can't, for I don't know, some other reason, until it has to, right? So
Yeah, and as a health plan, can you get over that innate? I can't. I don't want to help. I don't want to help my competitors grow. There's the general saying, a rising tide floats all boats, right? Can you get behind doing what's best for the provider in the process of taking care of their patients, whoever those patients belong to as a health plan? Can you help them give better care? Because if you can, then you're aligned with what that provider got into medical school in the first place for. That's what they want to do. So take my members out of this and focus on the patients for the provider. If you're helping them do better for their patients, you will do better with your members.
Well, and it goes to this whole idea of differentiation, because we have to, people ask us like, oh, how do I become the preferred? How do I get people to work on my documentation or submit that first? And, a lot of people turn to incentives, and we've had plenty of people talk about financial incentives, right? And that can be a piece of it, but it's like, it doesn't matter how big you make this carrot if you make the load unbearably heavy. And if you want to really stand out and be kind of preferred or remembered, or the top priority for your providers, like, make their jobs easier, make their lives easier, make the staff enjoy having to interact with you. And yeah, that may mean that other people benefit, but they're going to remember the health plan that makes those processes as simple as possible, or that provide the resources or the tools that allow them to not have to chase after their patients for 3 or 4 months or 6 months down the road when somebody's calling them to close a quality gap.
Yeah,
because they were able to take care of it right there while they were in the office.
Yep. And I think even sometimes we providers want to make money, right? We all do. We all are incentivized by that. But I think sometimes we misassign where that falls in their priority list in terms of how they make some of these decisions. And so, when we think about the diabetic eye exam piece, one big value that Viewpoint Diagnostics provides, the mobile vendor that I mentioned earlier, is as a provider, they submit claims for their services. So the health plan will actually have them go into these PCP offices, spend a day doing these exams for all of their diabetic patients, again, across payers. But then viewpoint will actually submit claims. So the PCP gets the benefit of gap closure. They get the benefit of identifying early who might have pathology and being able to refer them out for treatment and better coordinate care, but not the hassle of any paperwork. They're not submitting claims. They're not getting reimbursed for it. But you would be amazed how many PCPs aren't interested in that. They want to get the exam done so that these patients aren't going blind, right? And so offering that service in that way turns out to work really well.
And I think you touch a very important point, and it's at the end of the day, PCPs want to have a healthy population. So what is your take on primary care provider competition between each other? I know that they're very proud of what they do, and they want to, at the end of the day, keep their population healthy. So how can you see that role play on how we can improve quality, either from the payer perspective or from the vendor perspective, to see how we can make aware of how the doctors are competing between each other? Have you seen that?
It's an interesting question. I have, my experience with that has been more at a health system level, right? So when you've got a health system involved, not so much independent practices, but at the system level, you see a lot more of that competitiveness. I can tell you from the vendor perspective, we have definitely worked that angle where if we had a health system that invested in a technology, we would definitely work with them to promote that. And here's what this system is doing for their patients, right? And certainly the systems are competitive. They want to be offering at least the same, ideally better, in their opinion, level of care. So I think that is something, depending on what it is, the change that you're seeking, that you can certainly leverage. It's the same thing. It's the same, kind of competitive drive that we talk about with the health plans. Yeah, the providers have that as well, right? They want to have those members. That also goes back to, if you do understand that, understanding again, what are those internal incentives for why might I add this, right? We talk about maybe there's a reimbursement component, maybe it's a quality of care thing, but some of it is also, am I offering the most innovative, the most robust, right? Am I a system that a savvy or a patient who is really looking for cutting edge and wants to make sure I'm up on what's the latest technology that I have invested in. So I think that's a really good call out and something to definitely be aware of. Payers aren't the only ones that are competitive.
Yeah, absolutely. And it kind of goes back to really that old engineering maxim of what is measured improves, right? And it's more so than that. What is measured and communicated drives improvement. And I think that is kind of an underlying theme with a lot of what we're seeing in the whole value-based movement and quality care measures and everything else is, it can sometimes be questionable, as we've seen at plenty of conferences, as to what is actually being measured and are those the right things. And that is a constantly evolving conversation. But the fact of the matter still remains is that when people are given a target, they're going to be intrinsically motivated to hit that target. And if they can benchmark themselves against people they consider to be their peers, it is going to continue to drive that too. So I think that's a great point.
Yeah, one of my B school professors used to say, what gets measured gets rewarded, what gets rewarded gets done.
Correct, and that's a good point. We know that in this value-based care approach now, payers are incentivizing their provider network. And then, depending on the payer, they have different, of course, incentive plans. How do you think plays to the provider's mind this differentiation in incentives between payers? Have you seen anything in the particular service that you provide now?
Is your question if the different levels of incentives impact providers differently?
Correct. Some payers can incentivize only quality care gaps. Some can incentivize proper documentation on risk adjustment side. Some other could go into utilization management opportunities as well as pharmacy opportunities. So how do you see this differentiation between payers, and how do you see that the providers take that into consideration when they're closing these gaps in care?
Yeah, I'm probably not the authority on this by a long stretch, but from the interactions that I've had over the years related to the focus on the metrics and the incentives, my experience and what I've seen has been it may be even less about the incentives and how the incentives are structured than it is about the ongoing communication of performance to goal. Who stays present? Do they know where they are? Can they see where they are? Maybe there's a system they've got and they can see at any given moment, right? Here's where we are performing relative to our target. Do we know what that is? Because you can set the incentives and you can set the goals at the beginning of the year, and they're going to get busy doing any number of other things. And if that's not in front of them on a regular basis, so they know how they're performing and how close or far they are from the target, it's likely to fall off the radar.
Correct. Trackability is key. Trackability is key. What you mentioned is very, very important. So, like you said, you need to know what you're aiming for so you can reach those goals. And in the process, you get properly incentivized if that's what the health plan is particularly doing in that specific year.
Go ahead, John.
No, go ahead, Will.
It's making me. As a father of two elementary school kids, kind of moving up into those middle school years right now, like it just kind of reminds me of these correlations that we face our entire life, right? And going back, and we just had report cards come out and those other things, and it used to be, back when we were all in school, like maybe you got that progress report and you got your quarterly report, and it was a big challenge to know how you're doing, or your parents, like if they weren't right on top of you. But now, my wife and I can log into the teacher's grade book at any time and see how they're doing and how they turned in their homework. And at the risk of drawing too many parallels to kind of this paternalistic and relationship from a parent's perspective, just the ability to go in and to monitor and to be able to have those conversations with our kids has been a big driver in their ability to stay on top of those assignments, because it is far too easy to, as you say, even when there's big incentives, to wait until the end of the reporting cycle, and for whatever that is. And Jen, very well, just on vision screenings, like if people aren't getting those taken care of when they're coming in March or April and having those conversations, there's no way that a provider's office can go in and November and say, by the way, let's call our whole panel and go get them to have vision screenings in the next 30, 45 days. Like it's not going to happen. And those things have to be those constant reminders, because sometimes, unfortunately, we still see a lot of payers, even when there are financial incentives, they're only paying those out at the end of the year, and it's easy for them to forget. But to your point, even if they are only paying once a year, if they stay on top of the progress monitoring and make it easy for folks to see where they're at, they stay on top of closing those gaps in care, and it stays top of mind of incorporating it naturally into their workflows, making sure that all the boxes are checked, or at least as many as they can get checked whenever those folks are coming in, and making sure that they're coming in much earlier in the year so they're not getting overwhelmed.
Yep, 100%.
So I know we're coming up to kind of the top of the hour. Is there anything else that you like to drop into this conversation, or to share with folks? Maybe a parting wisdom from all three of those perspectives, right? Payers, vendors, providers, that maybe we haven't covered so far today.
Yeah, look, it's been a good conversation. I have certainly enjoyed it. From my perspective, having gone through the work of helping from the startup figure out the diabetic eye exam business, going through a couple of acquisitions, and ultimately building and leading our national sales and service team. I am a big proponent of making sure if you're a vendor, particularly if you're on the commercial side and you are trying to provide a solution to the market, that you're not selling features and benefits. Nobody buys your features and benefits. You need to know what the problems are of the person you're dealing with. And if you ever hope that somebody in a health plan is going to pick up the phone and take your call, you better understand what their equation is, right? What drives them? What boxes are they checking? What do they have to solve? And how do the numbers work for them? Because if you can't speak that language, you're going to have a really, really hard time getting their attention. And that may be to the detriment of a really important, meaningful solution that could help a lot of people. A lot of great solutions die because companies don't figure out how to get that done, right? And so that's a really big one. Exact same story if we're working with providers, just across the board. Do we understand how this entire solution impacts each of the people that are touched in this? We focus a lot, as vendors, we focus a lot on patients. What's going to happen with the patient? Is the patient going to get better? Are you measuring the right things? Right, for an Enzo Data that is pioneering this sleep apnea solution. In sleep apnea in general, most of the people in this space measure adherence, and they go to the payers and they say, look, the adherence is up. These people are using their CPAP more than they were. Well, the payer doesn't get paid on adherence, right? What they want to know is, does improving my adherence rate for this audience, for this patient population, is that going to translate to per member per month medical spend cost reductions? Is that going to reduce my acute utilization, right? What other things that I am responsible for is that going to impact in a meaningful, measurable way? Nobody's measuring that today, right? You've got to go beyond the immediate, this does this, and then say, okay, why would a payer care about that? Why would a provider care about that, right? And you have to play that all the way out, or it's going to be hard to get the right audience, to get the right attention, to actually bring a solution that could make a powerful difference to the market.
Very interesting point, Jen. Very interesting point. See how we can use one measure to define the triggers for another one. So very good insight. Very good insight.
Well, I certainly appreciate you taking the time to be with us here today, Jen, and the relevant contact information will be in the notes, and we tend to put these out on LinkedIn, and so we hope some folks are seeing some of these clips and will come to the website and watch our whole interview if you're only seeing a clip right now. But with that, I think we'll go ahead and call it a wrap, and I hope everybody can apply all of these great lessons and insights that Jen has provided to us today to improve your provider engagement and overall increase that quality of care that you're delivering to your members as well. So be well.